Welcome you all for the IITACB webinar series. And so, about very brief about our new audience. The IITACB provides a great platform to connect both the industries and academia together, and through the projects or through a lot of innovative ideas. And so today we have a very interesting webinar on innovations in healthcare. And I think that's pretty much the needed at the time in terms of technological developments. And our speaker is Dr. Ravi Bhardwaj, who is a Senior Director of Product Management for GE Healthcare's Oncology Solutions. And so he has quite large number of experience over 25 years, and he holds an advanced degree in biomedical engineering the from the prestigious university. And over the years, he has contributed significantly to the field of oncology. And he has been also focusing on the development and management of innovative cancer diagnosis, and also providing his contributions towards the treatment solutions. And so his academic background and professional expertise are published in numerous, the publications, medical journals, and where one can find all the advances what he has done over the years. And he also holding various leadership positions, including the roles in product management, program management, research and development, and including his career at GE Healthcare is also his commitment towards the advancing oncology solutions, which is really incredible contribution from his side. And his interest goes in the intersection of technology and healthcare. So his primary interest lies in the providing the solutions for the cutting edge technology to improve the cancer diagnosis and the treatment. And Dr. Bhardwaj's mission is to basically lead the development of comprehensive solutions that improve the patient's outcomes, and also the clinicians' decision support system and streamline healthcare delivery. So pretty certainly we really look forward to today's talk, and this incredible contribution from Dr. Bhardwaj in this important field. So this talk is going to be moderated by Dr. Anuradha, Dr. Anuradha, and she is technology director at GE Healthcare. And she is basically heading the Healthcare Technology and Innovation Center at GE Healthcare, which is in Bangalore here. And she also leads to multidisciplinary team of researchers who work across the multiple areas to develop novel solutions for the healthcare product. And she has enormous 30 years of experience in this field. So this incredibly goes very well with the all the technological developments and her contribution towards it. And so she is currently pursuing her doctoral program at Indian Institute of Management in Indore. So specializing towards the strategy management on a time scale basis. So I welcome both of you. And so today's webinar will be coordinated by Dr. Sushila Venkatraman and myself. And for audience, please post your questions to the to the using this question box, and these questions will be taken up during the break time and also towards the end of the today's webinar. So I welcome Dr. Bharadwaj to take up his presentation. Thank you.
Thank you for the kind introduction, Abha. My name is Ravi Bhardwaj. Very happy to be part of this series. When this was broached, I was really happy to be able to share some of the problem statements to such an elite audience. The views are personal. As I said, I'm just using a slide template, but these are my personal views about the topic and the disease. All right. So I would probably want to get your attention to an analogy, right? Let's say you're running, you want to win a race. You would have some strategy for figuring out how do you leap like a Usain Bolt or whatnot. But let's say you're running from an angry mob, right? That's when you get a um, uh, lot more strategic. You are trying all kinds of things to make sure you are not the last person in. You're maintaining a healthy distance. The analogy is a bit crude, but I think the point being driven here is you need to be smart with the cancer cells or the disease. You should always stay, or one should always try to be a step or two ahead of the disease. I think that's the point being driven. And how do we do that? By understanding the disease and by understanding the data and technology is basically the theme of the talk. So let's go here. A couple of challenges, right? Some are human challenges, some are disease challenges, etc. The amount of knowledge that is being generated because of the advancements in technology is humongous, right? So it is almost doubling every 60, 70 days, and how can a person keep up with so much of knowledge? And that person is typically a doctor who's treating you or diagnosing you. And the doctor would be challenged by a large number of patients waiting outside. So this is one problem, right? Growing medical knowledge, keeping track of it. The second problem is time to diagnosis and treatment, right? You let's say you figured out that this is prostate cancer or breast cancer. How quickly does your healthcare system get you to a confirmatory diagnosis and to treatment? Because if there is a delay in diagnosis or delay in treatment initiation, there is an increasing risk of mortality. And here are some numbers, but the take-home message is if there is a week delay, there's a 0.5% on an average increase in mortality. Okay? That's basically what we're trying to do. So our job as a society of researchers and technologists and clinicians is to bring down the time to diagnosis and the time to treatment initiation. Now, the third challenge in cancer is the web of treatments and the permutations and combinations of the choices. And not all choices, not all of them give you the same optimal output. Obviously, they will all have differing levels of success. So if you look at the amount of choices, you see that the disease also has multiple dimensions. The diagnostic workup, meaning where is the disease, what type of disease is it, what type of spread has it got, right? What's the geography and the biology of the disease? How many um, how many spots has it gone to, right? What is the suitability of this kind of disease to treatments, etc. There's a lot of possibilities. So you see that when a patient is diagnosed, they keep moving from one department to the other, right? So it's a very difficult uh, uh, experience for them. They're already traumatized by the diagnosis and the ongoing treatment. And to add to that is the complex workflow of appointments, referrals, keeping track of data, etc. Right? So in a nutshell, this is about the complexity of the enormous number of possibilities or the dilemma of equivalent choice. Right? Lastly, as a human being, right, we are still Homo sapiens. We cannot handle more than 5 variables for making a decision. Right? You cannot, as a human being, we are mentally limited to process more than 5 variables when making a complex decision. That's our cognitive load. And in oncology, you look at the number of variables, and even in the previous slide, There are a lot. So there is certainly a need to assist clinicians, right? And lastly, because of all the technology that we are generating, you see that we are generating enormous amount of data. Now you generated it. Now what? And who will analyze it? Who will extract the insights? Who will apply it to the clinical practice, right? So there is a need for crunching numbers, data to pull out actionable intel from this. Okay? Now, at the end of it, there are limited number of human beings who can deal with such a disease. You see that to produce an oncologist takes around 10 years at a minimum. Right? And for the oncologist to be um, wasting time in trying to read some things which are not really his or her core work, that's a criminal waste of their time, right? So there is a shortage of workforce. There is an increase in the incidence. You look at these are different types of roles. These role names change based on which region you're in, but as such, you know, the supply of oncologists and the nurses are going down. And oncology being a complex disease with a lot of financial and operational complexities, you even have less administrative staff, right? So so basically there is a workforce shortage, right? And what do the clinicians learn? If you look at what normal people learn and what clinicians learn, with due respect to the engineers and all the other streams, uh, medicine is slightly different in terms of how they absorb and read their stuff and how do they recall, how do they store, right? There's a lot of storage and live compute going on in their heads. Right? So you see that the knowledge has been codified into what you call as guidelines, and typically uh, oncologists are, I mean, in any other field, they are all trained on their standards of care. Likewise, in oncology, the clinicians learn the best practices which are codified into flowcharts like this or decision trees. Looking at this as engineers, you would probably have the thought of, you know, likening it to an algorithm. It is an algorithm. And the complexity here is that there are a lot of guidelines. This is one per cancer. They keep updating because you want to bring the best and the latest to practice, right? And as you know, these are meant to cover a large population. Therefore, there's always a bit of uh, choice issues, too many choices, because you need to cater to a broad section of patients. And it's of course hard to remember. So we will need to find a way to assist them so that they don't need to go to the guideline, rather the guidelines come to them or data comes to them, right? And they do their computing in their head. Right. So we will spend a bit of time here on this specific slide because one of my intentions was to make the problems more visible and appreciable so that some of you who are thinking of solving a problem through a startup or through a project can take up some of these and then bring them into practice. So on the top, you see that this is a typical care pathway. Care pathway is nothing but a sequence of events or phases for a cancer patient. And you see that there are different dots, etc. Ignore the dots for now, but this is imaging. You do screening. You try to find people who are vulnerable to the disease. Like people typically do lung cancer screening or breast cancer screening, which is a little more heard of, and prostate cancer screening. Women beyond 40, 45 years, based on their risk profile, are screened for breast cancer. Men beyond 50 years, 45, 50 years, are screened for prostate cancer. These are the two most common practices that we see. Same with lung. Now, uh, there are huge challenges. Imagine that you're going about your day job. Maybe you're given a set of things in the morning, and you've sort of planned your day saying that, okay, let's finish this by 6 p.m. and go home. Suddenly somebody brings 3x amount of work and dumps it, saying, hey, this is very important. We will need to get this done. What do? You make very hard trade-offs, right? Likewise, when people do screening, like screening through, you've seen RT-PCR screening, they put a swab inside, or screening through breast examination, screening through blood, etc. And that data needs to be taken to the department so that they can answer the question whether there is malignancy or not, whether there is a cancer or not. Because when you're screening, you conduct screening camps like eye camps, dental camps, and whatnot. If you do not find an answer saying go, no go, meaning do I need to hold the person or do I need to let the person go? Because remember, they are going about their day job, they're earning their wages. You need to quickly get to an answer saying, yes, I need to keep this person, something is wrong. Or no, seems normal, go back to what you were doing. If you keep on lingering, they will never come back. So one of the biggest challenges in screening is long turnaround time, because you now suddenly brought a whole lot of workload to the departments which have been planning their day, and they will struggle with it. They will slow down the reporting, and that causes the screening patients to disappear, saying they have other things to do, right? And that's the other challenge, right? In many countries, this is also not reimbursed. We also suffer from a technology issue here, which is a lot of false positives, which means that even if there is no cancer, uh, to err on the side of caution, people generally say flag it. Let's uh, get them to go through the uh, confirmatory workup. Right? Or the technology in many cases is not mature to clearly say yes or a no. Right? So generally people struggle with these false positives. Now, moving further, once a patient has been screened and then you find that there is something wrong, abnormal, they need to characterize that through proper imaging, high definition imaging, and a tissue sample. When you look at overall oncology, you are basically interrogating the body at the various levels, right? You're interrogating from an outside level, looking at what environment is the patient in. Are you exposed to any toxins, environmental toxins? Then they look at your organs by taking images, right? And then in images, when you do CT, MRI, ultrasound, X-ray, these kind of imaging, you do have an issue with skill availability. Not many radiologists are available, and therefore you have a long turnaround time. Remember from our previous conversation, if you take longer time to diagnose, you are adding more and more risk to the patient's success rate, right? Time to diagnosis is increasing. So you need shorter turnaround times. Secondly, the quality of imaging, or quality of detection or diagnosis, needs to be high so that the disease is characterized. This is key because treatment of cancer depends heavily on how it has been characterized. Is it stage 1, 1A, 1B, 2, 2A, 2B, 2C, or stage 3, 3A, 3B, 3C? And how do you come up with these stages? You come up with this by using information from imaging, from biopsy, from all the other tests. Now, if one of the tests is confusing, it leads to an incorrect staging or an incorrect characterization of the disease. Right? To touch upon a few other things, you see that when they do a biopsy is the act of going into the body, pulling out a sample of either fluid or tissue, and examining it at a cellular level whether there is something wrong or not. Right? And that involves taking out the tissue, preparing the tissue, seeing the tissue, and making sure that you can differentiate between the good and bad cells, right? And that takes time, and because these are molecular micro sized micron sized particles, you need to zoom them. A pathologist has to review that, and it takes a lot of time. For prostate cancer, it can take up to 3 to 4 days because the samples are so high, right? So there is a need to automate, bring intelligence for imaging and biopsy to deal with these problems. What is structured reporting? Structured reporting is answering the questions in a precise manner or in a to the point manner so that a clinician like an oncologist or a pulmonologist, etc., they get an answer very sharply, right? Rather than writing stuff that they're not sure about. So any confusion in diagnosis leads to confusion in treatment. That's basically the underlying thing. Now, after you looked at the tissue at cellular level, you go into the cell. This is called genomics by terminology. They're called genomic tests or molecular tests. You would have heard of that, genetic risk assessment, etc. So genes are tested from the same tissue that are taken from here. So one tissue is taken for structure, one tissue for function, one tissue for DNA, which is like our code. If you wrote a program, you wrote the code. That's the code that we all have, and all of our codes are different, right? And ultimately, now is the time to characterize the disease, saying what stage is the disease, right? So they use this information. I mean, they may not use molecular, but they use information like this and then say this patient is at stage 2B, B for boy, or stage 2C. Now, to do that, you will need to have very specific information from all the other departments. These are all from different departments. You also need to reduce subjectivity because today the age of the patient may not be factored in, or some other preferences of the patient are not factored in, right? So there are improvements happening to the way you're staging it because staging needs to be universal. It needs to be a common language, just like your USB. You define your own USB, it will not go into anything, right? So this is a universal synchronous bus. Likewise, staging has to be universal so that people understand it the same way, right? And finally, you need to also know if this patient is at this stage and I am going to try one of these 3 or 4 treatment strategies, will the patient respond? Remember, if you do a lot of trial and error, you're going to be, you won't be ahead of the mob. The mob will come very close to you or will touch you. So you need to be ahead of the mob, angry mob, right? So now you're entering treatment, right? What happens here, right? People find, more often than not, people do not undergo molecular testing because of awareness and because of guidance to clinicians also, and also because of a socio-economic factor in our country, right? Because it's expensive, but there are new startups that have come up, like food-based care, uh, with no prejudice to any of these. I'm not promoting any specific startup, but there are a bunch of these like Mall Bio and I'm not able to get the other names, but there are a bunch of those that have come into light, and then they're doing well, and that's specifically meant for Indian population and for Indian environment, right? So once you have your treatment strategy, the people, the oncologists, pathologists, radiologists, biochemists, genomic scientists, and mental health counselors, all of these people discuss the correctness of the staging and the treatment strategy. This is very unique to oncology. If any of you are impacted, your near and dear ones or your acquaintances are impacted by oncology related ailments, please remember that this is a multidisciplinary disease. Therefore, multidisciplinary skill is applied to answer the questions correctly, right? Is the staging right? Can the patient handle the toxicity? Are we respecting the patient preferences? So the shorter word is called tumor board. Formally, it is called multidisciplinary team meeting, right? MDT. That is where people check and they apply like more than one brains to that patient's case and then direct that case. And then it's like an oncologist taking approval, saying, hey, this is how I'm thinking. This is what the patient case. I'm going to go ahead with this. Somebody might say, hold on, there's a better option. Or somebody might say, hold on, please go check that and come back because this doesn't seem to be complete from a characterization perspective. Now, once we go along the treatment, you will see that during treatment, what's the typical, you know, what's a typical scenario, right? When somebody is unwell, they take some tablets and they wait to see if they're getting better, or they will go back and say not working. Same thing, patients are administered a regimen. There are three typical choices, whether it's a medication, otherwise infamously called chemo, where you give them tablets or drugs. It goes to the entire body. There's a certain mechanism of action, which is dependent on how fast your cells are growing, and it kills them. The second option is surgery, which is where people go and cut out the problematic area and ensure that the whole thing is cut out. The third way is to shoot energy like radiation or particles into that tumor area so that you can kill the cells. What do we mean by killing a cell? Killing a cell means you need to break the DNA strands. You need to, both the strands have to be broken, right? Either through energy or through any other means, or you inject some toxins and that cell dies because of toxins. Toxins go and cause destruction of the DNA matter or material. Right? So these are the three most common methods. Now, towards the end of this talk, we'll talk about some advanced methods where we will talk about one or two more advanced methods of treatment. Okay? So you need to ensure that you are taking the patient's comorbidities into account because ultimately you're killing cells. How do you kill cells? You kill cells by, well, killing them or by putting toxins into the cell or by shooting them with fire. In other words, shooting them with radiation, which causes heating in the cell and it kills the DNA. Right? So you will need to ensure that you're not harming other good cells as much as you can. There will be collateral damage as part of the treatment. The doctors struggle with, or there is a challenge here to minimize the collateral fallout. Right? That's another problem to solve to ensure that there is maximization of tumor killing, minimization of normal cell killing. Right? And that's one of the things about precision and personalization. Imagine that the patient is already anemic, meaning they have low hemoglobin count, and the doctor is prescribing a drug which is very good for the tumor but will further kill the hemoglobin. It is pretty hard to manage such a patient because they're getting a double whammy, right? So that's where the clinicians need to have an easy way to look at the patient's conditions, like comorbidities which are already existing or their specific preferences. In case of prostate cancer, there are choices of removing the prostate, choices of keeping the prostate, etc. And if the patient is in the sexually active lifespan, that's a very important consideration for choosing treatment. Sometimes they may use a parallel option in order to preserve sexual function, etc., etc. After treatment selection, while you are in the treatment, many patients do struggle with the toxicity of the drug. Therefore, they get so weak that they might drop off the treatment because they're unable to go and take the next cycles because toxicity is increasing and they did not see a doctor to get some relief. They probably are thinking this is the way it is. And so the important thing is when they have severe discomfort, see a doctor so that they give relief to the symptoms, so that you don't need to stop the treatment. So you keep going further, right? Uh, Pain management is an important aspect. There is a whole science behind it, right? Uh, and remission, right? After treatment is given, when the patient achieves a cure level or a response which is satisfactory, people either cut off the treatment or keep them on a maintenance treatment, like how people take um, um, glycomeds for diabetes. You manage, you give a maintenance dose, and during that time they are going about their daily life. The challenge here is to ensure that any untoward incident or any spike in some blood levels or anything different from status quo is flagged, so that they understand, so that the clinicians know and do some further debugging to ensure that it is attended to before it grows into a problem. Right? And finally, during recurrence, right, at some point, there will be recurrence. Recurrence meaning reappearance of the disease. And this is where we have a huge challenge, that we need to catch this ahead of time so that you have a time to treat, a window of time to treat. So we, as clinicians, not as technologists, they have to provide ways and means to crunch data and numbers to identify the starting of a potential episode. What it means is a lot of comparative analysis and analytics with respect to a normogram or a set of normal people or a set of people in that cohort. Basically, you're trying to say what's normal, what's abnormal, and then quickly monitor them more closely. Right? That's basically what they're focusing on. Right. Below are the metrics: time to diagnosis. So basically, from the time you have your first symptom to correct diagnosis, and time to treatment initiation, as you spoke about, time to start of treatment. Basically, right? You need to keep these low. In Western countries, UK, etc., they have a goal. The national health system needs to have they have a goal of 60, 61, 62 days for getting to treatment, right? And that's a very tall goal for that population. And likewise, this is called progression-free survival, meaning how long did you stay cured before the cancer grew or it went um, out of the jail, right? With the drugs, you're keeping them in control. When did it break free and start to move further, right? OS, overall survival, from time, treatment time till, time of death, is called overall survival. Okay? Palliative care is a word used to give pain relief. It's at a terminal stage. It aims at giving relief from pain. And as a country, we struggle with the lack of palliative services. I'm going to speed up a little bit. I'll touch a couple here, and I'm going to. This is a pictorial representation of the previous slide. As an example, what's going on in a doctor's mind, what's going on in a patient's mind, right? In a doctor's mind, for example, this is the tumor board that I spoke about. In the tumor board, assume that the case is presented of a patient. I'm a doctor, represented my patient's case. Now I'm asking them to vet my plan, treatment strategy, and to confirm my characterization or staging of the disease, right? And they will have some questions to ask. They will first ask, what is the variant of the disease? Is it an aggressive variant or not? Or they could ask, what is the impact of your treatment on their quality of life? What age are they in? Do they have children? Are they alone? It is surprising to note that there are a lot of people who may not know how to read or write. Therefore, instructions that are passed on to them by the nurses and doctors are not properly understood. So that is another small but extremely important factor to remember, whether their education level is sufficient to comprehend the treatments, the daily routine, right? They may even ask, what are the other first line options, right? So such kind of questions happen, and it's typically 5 to 8 minutes per patient. The discussion happens, and people may look at anywhere from 20 to 30 patients or 50 patients, depending on the hospital type or country policy. Okay? On a patient side, obviously, many of you can relate to this. What is my quality of life? What are my other treatment options? How much time do I have? An extremely painful question, right? For all of these, there are some models today, AI models, but not exactly in practice, but there some are in development, etc. So we have two challenges here. One is to get a model that allows a clinician to trust it, to a model to bring it into practice, right? Both have different connotations, which is why I divided them. Getting them into practice means that it needs to flow with them. You can't tell them, now you go to my application, log in, move this information there, I'll give you great answers. It's hard. They're doing 100 things a day. The other thing I spoke about is confidence or believability or trust. They're dealing with a lot of questions already. As I said, they're dealing with a lot of variables. You cannot afford to add one more variable. When anybody is creating a solution, there has to be a clear demarcation between where it works, where it doesn't work. Otherwise, it gets very complex for them to use. Right? Uh, let's pause here. I would like to invite Anuradha to quickly, react to this, and also to see if there are any specific questions that need to be answered at this point. We only spoke about problems. Over to you, Anuradha.
Hey, Ravi, thank you so much. I'm sure that this is just the tip of the iceberg that you have covered or unraveled in this whole mysterious disease of oncology. And like you said, there are so many problems or challenges that need to be tackled both by a practitioner or a doctor as well as by the patient. And of course, the innumerable number of people in the ecosystem who could be therapists, who could be pharmacists, who could be the molecule developers, the pharmacy companies, and so on and so forth. So thanks for this great introduction. So there are some very, I think, folks in our audience want to know, the expansion of the acronyms, which I know is little, you know, it is very, what do you call, a subject-based place. But as we go forward, let's see how we can answer those, actually open up the acronyms. Now, I have a specific question for you. So, a lot of talk is going on about precision medicine and personalized treatment, and you just talked about models. And I'm, I had thinking that these AI models are the one that help you get to precision treatment or personalized treatment. Now, from that point of view, right, what are the challenges that you see in personalization or of treatments for any individual, and also precision? And of course, precision and personalization are not the same. So any thoughts on that, Ravi, from your side?
Yeah, thank you. It's a good question. It also reminds us about the importance of data, right? Okay, let's talk quickly about personalization in one line. Many of us know that our blood pressure gold level is 120 by 80, right? I think, or maybe 60, I don't know. But do we know whether that belongs to our population? 120 by 80, is it for us or is it for somebody else? Most likely, don't hold me to this doesn't belong to the Indian population. It is a number from a Caucasian cohort, right? So what I mean by that is that this demography, Indian demography, may have a different average number. Maybe we are 130 by 90. You go to the farm side, to the village, there living pretty strong, they're doing very well, they'll never have 120 by 80. Right? So personalization is in a single line. Will you respond to this treatment with a 60% probability as compared to today's answer that we get? This drug works 60% of the time or 60% of people. The question is, am I in that 60% or am I in the 40% where it did not work? So personalization is ensuring that you are in that this works on you, not amongst 10,000 of you. Right? That's one. Precision is basically going down to the point of saying this is my narrowest root causing that I have done, so that my solution can also be narrow. So this is broadly the difference. So what we need is precision and personalization at scale, right? You need data to ensure that this drug or this method works on this class of people. Therefore, you would be able to then say, I can personalize your treatment for you because 50,000 people who are like you went through this. You are very similar to those 50,000, and therefore you will respond to this treatment like how they did. So this means that you need to collect data and start slicing it in different ways. I hope that answers the question.
Sure, Ravi. So I'll take some questions which have come up on our board. So right after the data. So the question is, are there high quality data sets available in the public domain for startups to test their algorithms? Could there be the radiology databases or others? And is there a possibility to share these sources?
Okay. It's also another good but a stumping question. Many of the startups uh, have been using US or Europe based data sets, which are typically results of grants. Right? In India, the movement has started to collect data, be it tissue data, be it imaging data, be it dietary or be it exogenous data, right? Um, there is a project called MIDAS. I'm naming just one amongst 20 or 30 of them, called MIDAS, which is a good collaboration between Indian Institute of Science, um, TMH, and a couple of other AIMS and other people, where they started to get a tissue bank and they've digitized those slides, the tissue slides, pathology slides, and they're starting to store for oral cancer. Now that's a beginning, and now we see that the country is putting in a lot of money into data storage. Now, there are a few other dependent problems. Uh, Collecting data is not as straightforward that people can just store it and share it. There is a privacy concern with respect to that. There is also an association concern, meaning you need to preserve the associations or relationships between different data points over time. Otherwise, you have lost a temporal nature of the data. We need easy ways to do de-identification of data. We need clean ways to ensure that we take consent from the patient, etc. So I think the country has moved a long way through ABDM and consent seeking and revocation is now part of that platform, etc. So the policies are being made, infrastructure is yet to be available. It's promising. That by itself is a multi-million-dollar startup problem to solve. And if anybody wants any specifics, we can connect offline. But that has a lot of problem statements. The punchline is, how do you turn inactionable or idle data in a hospital into actionable, fruitful outcome, right? Simple examples, you get new drugs from the West, do you know if it works or not? You have to do a clinical trial. You have to do a trial, you need to enroll people. That takes a long time. But if you had stored data, you can do an in silico trial or a retrospective trial and quickly bring the drug to the market. That's just one example. So that's where I would probably, pause. I hope I answered it. It's a long answer. Sorry. Yeah.
So Ravi, maybe we'll take one more question before we move on. So this is basically about how do clinicians trust your AI tools, right? And do they trust? Do they use them? How do you help them inculcate the trust? And how can you better integrate into clinical workflows so as to build the trust?
Yeah. Okay. So in a way, this is a rocket science question, and it is not. Uh, let's assume that you are given a self-driving car by Tesla, whatever, in India, and you bought it. You got suddenly rich and you bought it. Now you want to use the auto drive feature or self-driving feature. You're going on a highway, you're feeling sleepy, and the first 1 month, will you sleep? I hope not. Right? As a human being, we don't trust something until we have some proof points. We also need to know, as I said before in one of the other passages in the talk, you need to know where it works, where it doesn't work. It is not humanly possible to make it work all the time because it's a probabilistic technology. So it's important to say it works here and doesn't work there. Make it more detectable. So even the same thing happens with doctors. Is of course a lot at stake. Just like your own life, when you're trying to sleep at the wheel because it's a Tesla car, you would want to check or validate as a human being what kind of scenarios does it hold up to? Does it hold up to the normal things that you know? And does it hold up to the things that you don't know? That's the tough part, right? Will you trust your own knowledge or the system in case of a dilemma? That's where there needs to be a way to say, don't trust me, go by your own judgment. Or I know this because I can explain this response as a model. Therefore, believability has some factors to it. In the interest of time, I might not be able to go into all of those. Critical factors for believability include detectability, but includes telling you how it came about. In today's world of multi-agentic frameworks and reasoning agents, one of the ways to ensure that we believe the answer is to make the agents spit out their chatter so that you know how it arrived at that. I'll pause here. I hope, but we can engage in a conversation separately. That's also a passionate area for me, and of course, for many of you.
Yeah. So Ravi, there is one last question before we move on. Is cancer hereditary? If so, what is the probability it does not, it passes to the next
Okay,
or to the subject? Yeah.
it's a good question. Cancer is a disease of the genome. Okay. Uh, just quickly connecting this to the previous question of normograms, even our gene details are based on a normogram that should belong to our race or ethnicity. Today we are using this from the Caucasian numbers, but now that aside, it is a disease of the genome. So let's assume that you are writing a complex software program and you made a semantic, not a syntactic, a semantic error. You made an error in the logic. Now it is released for production. Now it's a huge program, and it's like a bug that many of you have experienced that you could never reproduce and fix. It's somewhat like that. It's a disease of the genome, meaning in the coding of the DNA, there is a problem which causes it to produce either more purines or pyrimidines, or it causes an issue of imbalance of uh, uh, for the sake of brevity, proteins, certain proteins. There's an imbalance in production of certain proteins, which leads to this. Therefore, it can be hereditary. There are variants of cancer which are hereditary and which are not. The ones which are not hereditary are things that you got from the environment or from an external factors. They are called somatic. The ones that you got from your hereditary line, family line, is called germ line. Right, as the word says, it's germ line. So that's why, as part of the molecular testing, there is that's the reason why you need to do testing. You will know whether it's a genetic variant or a non-genetic variant, and that is important, right? If it has got a genetic or hereditary nature to it, depending on where it is in the chromosome, you will need to take additional precautions, go through genetic counseling. That's, I think, a short answer.
Thank you, Ravi. Let's move on to the second part of your presentation, and then
Okay.
we'll take more questions towards the end.
Okay. I'm going to touch a few solution examples. Here is where we'll jump a little more into some kind of a real worldish treatments and all of that. Let's quickly. Okay. So I'll try to finish this in 15 or so minutes, so that we spare time for any questions if there are. Okay, so I'm giving a breast cancer pathway as an example, and now I'm talking about some technology-based solutions and startups with no prejudice to any startup that's present here on the screen or not. I'm not promoting any startups or hurting any startups. It is just an example for sake of illustration. So if you see on the top, this is typically how a breast cancer set of events or procedures happen, right? You do some kind of a mammogram. Mammogram is painful, but you need to do it. The breast is compressed so that it's a uniform kind of a sandwich, so that attenuation of the X-rays are uniform, and it's only attenuated by changes in tissue. And it basically is X-ray based. You will see some kind of calcifications or whatnot. Or you could also do with ultrasound, which is like a handheld ultrasound. You will see differences in the tissue type due to the ultrasound propagation. Or this is a third one, which is an interesting one, which is called ABUS, automated breast ultrasound. The difference between these two ultrasounds is that this requires human skill in order to see where you want to point and see. It's like a torchlight into the body. You'll only see what you're pointing at, whereas here it'll do a complete horizontal ultrasound. You can basically do this with a non-medical person or a very lightly trained paramedic, or even of a lesser training. So you see that this is screening phase. This is diagnostics, where they do a biopsy using the guidance of an ultrasound. And you see that there is a mammogram, which is of a very high definition. And as we spoke about some challenges of long turnaround time or loads, etc., I wanted to get some attention towards an interesting set of startups here. You would have heard of Niramai, which is a thermometry-based AI product, which uses thermal or FLIR camera. This is led by Geeta Manjunath. She is a very prolific person, scientist and a researcher. So this does a thermal picture of the breast. Nobody needs to touch the breast. Nobody needs to see it. Operator is sitting somewhere else. So this is a very well suited thing for one part of the world. A picture is taken in 3 positions, and then they analyze 2 to 3 million pixels and give out a result of potentially malignant spots in under 5 minutes or less. And that can be used to confirm whether you need to go to the rest of the diagnosis or you can go home, right? Typically, that's what happens. If it's a normal breast, if there is even a slightest doubt, they go till a mammogram and then send them back. If it is seemingly malignant, they will go through the rest of the pathway. And the other one is a piezoelectric method based breast, which is, it's called iBreast exam. It basically uses, shear waves to see difference in the breast texture. The sensitivity is higher in this case. So this solves skill. You have AI based something. This solves operator skill, reading skill, and you can use this report to be given to a radiologist who can then say, I will check for these when I do the high density or highly accurate mammogram. Right? It is input. It's guiding you what to look out for at a minimum. It also is easy to it solves a cost problem, quality problem, and an access problem. Access is it's just a tripod and a FLIR camera, no big deal, cheap, because it doesn't involve a very huge method to do screening, right? You can push them to the cloud. You can do operationally very well in order to give answers. And by the time they get back into their robes, you can give them an answer saying go home or go to the next door, which is the next diagnosis. The other phase of this is molecular testing and biopsy testing. As we spoke about molecular things and even mammography, it is hard to read them. You need to report them in a certain way, what I refer to as structured reporting, which means that you need to speak the same language. You need to speak unambiguous language when you're reporting it as a radiologist. And you also need to guide where the tissue needs to be taken for biopsy. And when the biopsy tissue is taken, you need to examine that. You need to, when you magnify it 40 times, it's a lot of area to cover. So you have seen models like ProfGigPath and other new foundation models that came in for catching and counting and characterizing cells at a cellular level and at a tissue level. And the mammography, we have seen solutions which give you a structured report, forcing the clinician to ensure that those are answered rather than leaving them blank and leading to ambiguity. And they also segment the required potentially malignant spots and giving their metrics, because size, location, shape, texture are all extremely key to suspect if they are malignant or not. Okay? So, in this case, in pathology, you see that there is a lot of number crunching that needs to be done. So this is actually a Hyderabad-based company. This is Bangalore-based. These two are also Bangalore-based companies. And you see that in pathology, you'll be able to do a lot of counting. Many a times, as I spoke in the previous slides, if you do not characterize this properly, instead of 2A, stage 2A, you said stage 2B or stage 2C, the treatment strategy changes. You are potentially denying them treatment, which could have given them more prolonged life. Or instead of 2C, you said 2A, you are denying their cure because you did not use enough firepower onto the tumor, which means that the mob will get ahead of you. That's the analog. So you will need data-driven decisions to be made. Therefore, onward assist or any other, there are a bunch of others, couple of others also. They actually give you quantitative metrics which allow the pathologist to quickly create a report and get back to the oncologist saying, hey, here is my report. This is what I think is the stage, move forward. So from 5-6 days, it becomes like an hour or two for reporting and quality checking. In all of these, there is a human in the loop. to ensure that there is a check from our side. But to the question that came in the chat, you cannot assume, you cannot add more cognitive burden to the clinician. You have to help them saying, this is my area of confidence beyond 80-90%. This is my area of low confidence. You please confirm through your own methods. That distinction is extremely important, and explainability as to why you're 80-90% or why you are this. Right? There are many strategies of giving them that explanation. We can probably touch that offline in some other sessions. And when you are in staging, you are saying that, hey, this is the treatment strategy, this is the stage. Now, when you go into the staging discussion, you'll need to also know what kind of treatment has to be offered. And not just offered, the key word here is what kind of treatment will surely work. That's the difference between what you're offering and what you know will work, right? That's the difference between precision and personalization versus just giving them a treatment empirically, right? Empirical methods have their own strength, but when you have the options where it suits socioeconomic factors and infrastructure, please do go for precision and personalization methods. So these are companies which actually are working at a molecular level. This works at a protein level. This works at a gene level. Both of them are based in Bangalore. And they will also tell you, they will inform you, and there are a few more companies, whether this disease variant is aggressive or not. Therefore, should you shoot it with one bullet or maybe 5 bullets? Or in other words, saying, should you use one drug or should you add a second drug to the treatment so that you are treating it with the right level of aggressiveness, matching the disease aggressiveness? Okay. And finally, during monitoring, what I did not write here is liquid biopsy. We need to check whether there are differences in their status quo, in their blood counts, in their imaging picture, because you never decide to do something by just looking at an image or by just looking at bloods or by just looking at their symptoms. You put all of them together because it is a multi-point support decision making that humans use. It's just like you not buying a car just because it gives you more mileage. You will look at seating, you will look at drive comfort, you will look at the longevity, you look at service costs, etc. Likewise, you look at how are they doing from what is imaging telling me? What is the blood telling me? What is a tumor marker or blood level of a certain marker telling me? What is a patient telling me? Once you lock in all of this is when a clinician makes a decision, right? These are some typical questions. I will not go through it. I think I touched upon this. This is for a prostate cancer. You can look at it later. There is a question about germline, which you need to do if someone is detected for cancer. These are some companies. This is not an updated list, not exhaustive, in different segments of the journey. In the interest of time, I'm trying to get to some interesting slides very quickly. Here is the state of the art. By the way, these were all things that use very good modern methods, combining both machine learning and biology, right? The power is using the domain and the technology together rather than sticking to one of them. A single point of support is not helpful, is not robust. Now, let's look at some quick diagnostics very quickly. I think this slide is here to tell me and all of us that there is a way to do molecular imaging. All right, so I'll explain the word a little later after a few slides, but imagine this, I gave the analogy of a mob, right? you're running, mob is behind you, and now you're trying to see what do they have in their hands. Are they just running? Is it just a marathon, 5K marathon that they're all running generally and it's not a mob? Or it's a marathon with a few dangerous elements, and you just need to see whether you can attack only those elements and then diffuse the situation. Meaning, in all of the cells in the body, which ones are cancerous specifically? How do I know that without doing a lot of invasive procedures, or cutting out a lot of tissue? So one of the ways is to see what are they expressing. For example, there is a burglary, God forbid, there's a burglary in your house, and your house is next to a lake, there's a swamp, and there's a lot of mud. It rained previous day. And you've called all the people, the police has called everybody to stand in the queue. You will see that everybody's standing, everybody's smiling at you. How do you know who the thief is? Obviously, there is a swamp. Anybody with mud on their legs or hands are highly suspicious. Some of them may be good people who are working in the field. Other people could have been the ones who committed the robbery. Like anything else, when you do something, a few good cells also get hit. So you would now see that these are the people, anybody with mud, they need to be interrogated further and processed further. Likewise, for cancer cells, which are actually behaving like normal cells, they're extremely smart, by the way. They're smarter than normal cells, which is why they're they're uh, 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 they're able to overcome our immune system and our own defenses. They will act as if they are normal, but you found a few things which are abnormal. And that's what you catch on to and look at where all they have gone. Have they formed colonies, right? So that is called molecular imaging with a specific, binding protein. In prostate cancer, we use what's called gallium or a version of fluorine. These are radioactive isotopes, so that when they go there, you can use a radioactive detector to see where they're going. And it's like a flash. You take a picture, those things stand out. Rest of them look normal. Okay? Um, so the next method of precision is genomics. As I said, this is a disease of the genome. There's something wrong in the code. Someone wrote the wrong code in your banking software. Every time you're doing something, you're losing 5 rupees. Right? You need to go figure out where the hell is that code, right? So in the workflow, when they do a tissue sample through biopsy, a part of it is preserved to be sent to a genomics analysis test. Like Tempus, Caris, Foundation One in the US and UK and Europe. We have a few in India, which are recent, which is the 4-base care, as I said, and there are a bunch of others, MalBio and BioFire, a bunch of things others. As I said, no prejudice. They will take that and they'll analyze that and into what you call as a next generation sequencing NGS scan or a machine, and they churn out a huge report. Now we will quickly talk about what or how that report means. This is going down to the gene and the specific damage to the gene, right? Is something deleted? Is something added on the gene, right? Is something modified, right? Here is a quick example. I know I'm running short on time. Let me check. Anuradha, how much more time should I do? A few more minutes?
Yeah, maybe 5 minutes, Ravi.
Okay, thank you. So here is an example of a first page of a small booklet that you'll get, right? A genomic report has a lot of information in it. And perhaps you may all be surprised, not all the oncologists are familiar with interpreting genomic reports and prescribing the right treatment for it. Therefore, there is an awareness issue of recommending for a test, interpreting the test, and also getting treated. There are a lot of ways and means now that we can reach out and get the right characterization. And we are starting to get this at an affordable price now. Affordable is a relative word. I'm sorry. I don't think it's now at the cost of a blood test, but it's expensive. But I think it's come down from where it was 5 years back. So here is an example, right? what it is trying to say is how is your immune system, right? How are the specific markers or status indicators of your immune system doing? Then it comes down to say, which are the genes that it tested. Typically, it will test 20, 30, 7, 5, 10, 15, whatever, because the narrower the search, the better. Let's say I do 20 panel or 20 gene panel. It found the following abnormalities in these genes. ALK, CCND1, etc., in the tissue that was taken from lung. This is a lung cancer. And now it will go down further and tell you, here is the immune system status. Immune system is like your police force, right? If you have enough police force, you can take on a mob. If you don't have enough police force, you need to get them from the next state. And I'm using these analogies to some methods, right? If you have enough immune system and the thieves are hiding, all you need to do is to tell the police how the thieves look, how they behave, where do they live. So likewise, instead of giving a lot of external drugs, you can signal the ecosystem, the immune system, to say that they need to go and attack certain types of settlements in the body, cell types, etc. Right? Because what you need to do is to point to them saying, this is a bad guy, guys like these are bad, go kill them. Right? So you're using your own immune system to fight them. This is called immunotherapy. Recent, relatively, and quite effective because it does not use external chemicals. Toxicity is lower. Toxicity meaning unprocessed chemical in your body that is damaging your liver, kidneys, and other parts of the body. Like when you take too many antibiotics, they need to go act somewhere, they'll do their damage. The undesirable actions are called toxicities. So after we are done with immune system priming, if the disease still goes further, is when you start figuring out where can I target this even sharper, right? So that's when you go to the source, which is through a genomic test. Here is where it is saying this gene has a problem of a fusion, meaning this and one more piece joined. Because of that, it is doing something stupid. Therefore, you can try using a drug or drugs that are designed to correct that, to remove that defect or correct it and solve the problem. Until the defect changes, then you have to change the treatment also, right? Or you can use another type of treatment if the patient cannot handle this. But basically, it's a plan B situation. Okay? This, in a nutshell, is how a certain vendor or everybody else typically will show the information for precision diagnosis, right? These are the precision treatments. These are precision diagnoses. Same example. I would just quickly touch upon one or two methods and then we'll stop, right? This is a very recent state-of-the-art therapy. And just imagine, we're talking about surgical strikes, etc., right? This is a surgical strike. So let's assume that you are again in the thief example, you found out, or okay, number one, you need to find the thief, right? Anybody with muddy feet or muddy hands need to be caught. After you catch them, what do? I don't think you'll hug them, right? You'll probably take a knife or a hammer and bang their head, most likely, or tie them into a rope and then do whatever, right? And hand them off to whatever. So exactly to that point, you are not touching those people whose feet are clean, right? In traditional methods, chemo, etc., and even radiation therapy, you will kill a class of cells which behave similarly, including the ones that are healthy. and the ones that are not healthy. Because empirically, healthy cells will recover to some extent. And the job is to kill the unhealthy cells, right? That's the first priority. Even if some other cells die in the process, benefit is more than the risk, you will go with that. Whereas here, you are specifically finding out which are the receptors, cells with muddy feet or hands. And now you will create a molecule that it gets attracted to mud. I'm paraphrasing, by the way, right? Uh, it's a ligand, meaning it'll go and bind to all the muddy feet and muddy hands. Once it binds, imagine that it will tell that it caught the thief. It will release its payload, meaning the hammer. In this case, it's a beta particle or an alpha particle. So look at how specific this is. It's going to a cellular level and catching it and killing it without damaging things around. Very, very minimal damage. Very, very minimal because it's acting at cellular level. The word theranostics or radiopharmaceutical therapy is that with the same muddy feet, you can develop a camera that catches or that takes pictures of muddy feet only, removes the rest of them, or you can take a hammer and bag only the muddy feet. So you can diagnose those muddy feet, or you can diagnose those specific cells, or you can basically image those specific cells that are emitting that specific cancerous protein. I'm simplifying it for the sake of the broadness and brevity. So you can image using the same protein and see where all it is gone, get your treatment strategy, and then you can send the army, or you can basically send these heat-seeking missiles, if you will, go and destroy only those targets with the payload that it has, right? So this is basically what it is. You have an oncologist who does imaging of the muddy feet using gallium-68 radioisotope bound with this mud. This is the mud analogy that I was using, prostate-specific membrane antigen, which is emitted only by prostate cancer cells, right? And you image this because of this gallium-68 being a gamma emitter, and this is a gamma detector. You will see where it is in the body. Then you see what kind of strategy. Has it gone to many tissues? Is it stuck? It is stuck to only some tissues. And then you see, let us treat this patient with this kind of a radionuclide with the payload. Now I'm going to bang it, right? And then see the difference, right? This is how it was pre-treatment, right? This is the first cycle of infusion. This look and what is used to treat is the one that actually has particles. What is used to image is the one that has rays, because that's gamma emission. These are things with hammers and knives, because those are particles, alpha particles or beta particles. So you inject them with the same mud attracting ligand, but with a hammer. They will go seek out those tumor cells, and you will see that they've killed some. And then after the second round, they've killed some more, right? And in November, it's almost normal gallium. Ignore the kidneys being bright, that's normal. But see the dots, right? You see the dots. These are game-changing therapies. Okay? Incidentally, they're being offered in India also in many cancer centers. Right? We don't need this. The second, this is the end of my talk, is the same thing, this exact same method. Let me go back. Here, replace the radionuclide with a toxin or a chemo molecule. Everything else is the same. You go bind, you hold the payload. This is a holding tank. This is the chemo, and you bind and you release this, it'll go to the nearby cells only that it is bound to, and it'll inject toxins, it'll kill that cell. That's called antibody drug conjugate, right? So this is a non-radioactive version of the previous method. Okay. I'm going to touch only one here. I'm just picking which slide. Uh, okay, let's just talk about this. Now you're in the monitoring phase, post-treatment. You need to be monitoring for something that's going wrong. One of the things to solve for is, for example, somebody had vomiting, or maybe somebody had a fall. They fell down. They fell down due to what? Did they fall due to tripping their leg? Did they fall because they felt dizzy? Did they fall because they are not able to eat well and therefore they felt weak and they exerted and fell down? Why did they fall? That could have been due to the drug that they were on or they're on, which is on a low dose maintenance. That could have been due to the organ itself, which is already under a lot of damage, or it's because of some pre-existing disease not related to cancer. Which one is it? So you need data, differential diagnosis, multimodal algorithms to root cause this so that we know whether they should go to a cancer clinic or to normal clinic. It's a sea change of difference going to the wrong clinic because they're different, right? Vomiting due to bad food poisoning is very different from vomiting during the treatment given for cancer. So there is a lot of work here in checking remote vitals, triaging those vitals, juxtaposing that with blood tests, etc. So building multiple points of support and watching the patient very closely. Have they reduced their physical activity? Have they reduced their intake? Did the weight go down? Is the blood pressure, shooting up and down? What's going on? How is their psychosomatic state or mental state, etc. Right? So with this, I will pause. Hopefully, I gave some, uh, you know, context to the disease, the problems, and some example solutions. I could not touch too much on the technology, but maybe we will do in subsequent sessions. Thank you very much. Over to Anu.
Hey, Ravi, thank you once more. I think those analogies were wonderful examples to help us understand the concepts better. And yeah, I think it would have given a lot of perspective to everyone on how some of these are done. There are a few questions. I will quickly take them in the interest of time. Okay, one of the first questions is the thermometry AI aligned with BIRADS?
Good question. It does not give you a BIRADS. It supports, it's an adjunct screening device. It cannot give you a concrete BIRADS by itself, but yes, it helps in estimation or a strong guess, but you cannot complete the BIRADS without the remaining workup. It's only a beginning to suspect and to take them through the confirmatory diagnosis, because there is a lot of false positives. This kind of testing helps to focus on people who actually need to get biopsies and mammograms.
Okay. So how economical is RPT compared to other treatments? Or how is the demand and supply of radiopharmaceuticals most likely in our country? I'm assuming it's
Okay.
from us. Yeah.
Okay, good question. First part is it is expensive right now, but relatively lower in our country as compared to others, partly because we are still not heavily regulated. Only AERB is, or the bar agency is regulating us in this country. It is expensive because you need to create this very minimal contamination. Production facilities are expensive. Cyclotrons are expensive, extremely specialized skill. So it is more expensive. Now, it is not it is in the same league as the other advanced oncology treatments, which are targeted therapies. It's in the same league. It's about the applicability of which treatment the patient is suitable for. So they are right now, there is more work to be done to bring it down to economical levels, I would say. Targeted therapies like radioligand therapy, ADCs, and other immunotherapies are still expensive. Immunotherapies are somewhat affordable in a scale. Chemo is the lowest, immuno is the next, targeted is the next, and RPT is in the same range. Production is a challenge. What we are seeing is that the domestic production seems to have contamination for lutetium and actinium and astatine. So it's needing to come from other countries. So that's another point of innovation needed. Thank you.
Yeah, not just that, right? The complete workflow has to be revamped in order to administer theranostics.
Yeah, it's a hot lab, right? You cannot have a
Yeah.
person taking it and walking around with everybody else. They need to be put in concrete rooms, radiation safe rooms. All right.
Yeah. One more question. What are the practical considerations for managing the enormous data volumes generated by high-resolution computational microscopy in a clinical setting? And how can real-time processing and intelligent data curation mitigate storage and transfer bottleneck? And maybe you can also tell us what's the percentage of diagnosis practically can be achieved through light microscopical diagnosis? Do we really need all that data that is generated?
It's a good question. Uh, so the way the tissue is acquired is from the tumor, right? If you assume the tumor is an irregular mass, you will need to see both normal and the abnormal. You need to cut through it, right? You need a slice that cuts through it. There are some other considerations of how to analyze it. Your cross section, is it complete with tumor? Is it 50%? It's called core length, and there are a couple of other definitions, but you need a tissue which contains both normal and abnormal, which is how typically it is sampled, and it is magnified. Today, yes, you want to look, there are standards of care, of reporting, that necessitate that you need to look at these many areas in a slide, like typically 50 fields of view. These are magnified to 40x. So it's a long question, but I think this is where the foundation models are coming to the rescue. Propagate path, etc. People are really using it. Other important thing is you can afford to do this non-real time for most cases. The desire is to do real time, but there is always a gap where you will need to take the tissue to make it visible. You need to stain it so that only the nuclei, etc., they take the stain, or you give another stain to it, which is like, imagine your camera filters, red filter, blue filter, or that you use, and you see only that. So you need to stain it, then digitize it. So there is some time that is involved. So we can strategize based on the available methods that we can use that to our advantage and do batch processing and compute all the areas of abnormalities, reduce the number of fields of view that they need to inspect. For sure, it is going to be better than what they're dealing with right now. We can talk about this more. I can connect with some people who are really good in this space. If somebody is trying to solve this problem, we can talk offline.
All right. So, Ravi, one more last question before we give it over to Sushila. Is photoacoustic imaging being targeted for cancer detection?
Now, I'm not an expert in that field. I may be out of my depth. I can speak about photo and acoustic separately. Putting it together, probably I'm guessing is combination of outputs of those two methods. Photo is popular in oral. Acoustics is popular in breast and in abdomen. I am not aware of standard of care devices that employ photoacoustics. I'm sorry, I'm a bit out of my depth there, but that's the best I can come up with right now.
Thank you so much, Ravi. Amazing talk. And
Thank you.
I hope everyone learned from this as much as I did. And once again, thank you, Sushila. Over to you back.
Thank you. Yes, it was absolutely brilliant. And certainly, I think a lot of us learned a lot. Some of the comments that I've been getting offline, talk about have expressed how much they have enjoyed this talk and how much they've learned. So today we started by looking at challenges in cancer diagnosis and treatment. And some of the challenges that we looked at were how knowledge in medicine, medical knowledge is doubling every 73 days, if I remember right. How vital it is that both time to diagnosis and time to treatment are reduced on an ongoing basis. I think UK, you said, has set targets, and hopefully we will see that happening more and more frequently, and the target also coming down over time as technology grows. The disease variability is very high, and the choices are very many. So there is a huge complexity of both in diagnosis and in treatment. You said that humans can handle at most 5 variables, and obviously, as you explained, there is very much more than 5 variables that are involved in whether it's diagnosis or treatment or across the whole care pathway. So there are also other factors that come in, such as the environment that the patient is in, the patient's own preferences, comorbidities, etc. And therefore, the importance of personalization is again a very, very important aspect when we look at cancers. Obviously, there is a huge amount of data, but what do you do with this data, and how do you get some intelligent, actionable insights from out of all of that data? That's a big question that sits out there. You explained that there are standards that need to be followed and correct characterization, how critical it is. Similarly, the clarity and accuracy of communication is just as important. I'm just picking up a few key points just to kind of round up everything that you said. It is a hugely multidisciplinary effort, and Ravi presented to us a detailed analysis at every step of the care pathways, highlighting the challenges and key issues that must be taken into consideration when you look at each element of the care pathway. And all of this, of course, needs analysis of heaps and heaps of data, the definition of, and another important thing is, how do you define what is normal or abnormal for a specific reference set of people, and that is where that whole question around India and how do we create data that is relevant to India. You talked about the Midas effort and how that has started. Incidentally, the IITACB also hosts an AI center of expertise and excellence, and we would love to kind of take this discussion forward on that. You talked about the various. We then looked at many solutions and the emerging technologies and solutions, AI models that are under development, but how do we make them trustworthy and believable? What are the factors that go into defining what is believability? Challenges in personalization, whether and in precision in understanding what the root cause or the root issues are, is again critical in terms of a good outcome when it comes to cancers. So we looked at a few indicative technology-based solutions in different areas across the pathway and for different types of cancers as well. There were examples of evolving technologies, the different kinds of tools that are now available. And then we also looked at emerging areas such as theranostics and genomics and so on. So this has been an absolutely fascinating session. And obviously, technology has a huge place in terms of what is required to deal with this big problem that cancer is for the country. We are planning for the audience, we are planning a whole series of webinars around this. And we hope to bring in conversations with startups and clinicians and technologists and so on. So please do stay tuned in and watch out, look out. We will be announcing a few more of these webinars. We look forward to having you there as well. And thank you ever so much to our wonderful audience, both for being part of the audience and being with us through this webinar, and for your questions. Questions always enrich the discussion. And Anu, you have presented to us before on technology in healthcare, and not in the webinar, but at the IIT Alumni Center. And I think every one of us learned and gained from that session too. So thank you for being here, for moderating this discussion. Ravi, thank you ever so much. This, we hope, is just the beginning of a long association that, how can we get together and see how to deal with what is a very big problem, both from an emotional perspective and from a financial perspective, from a medical perspective, quality of life, just about everything. So yeah, we hope that we will together be able to find good solutions. Our audience, please do write in to us. We are more than happy to associate with you. With that, thank you very much once again.
Thank you very much.
Seeing you later. Bye.
Thank you. Thanks for the opportunity. Bye.
Bye.
Thank you. Bye-bye.
Bye.